Hi, everyone. We will get started in just a few seconds here. All right, let's get started. Hello and welcome to the 2026 winter session of the NAPSA Research to Practice webinar series. My name is Jennifer Cotter. I'm a director at Evident Change and today's webinar moderator. Today's presentation is titled Outcomes from Colorado's Alternative Response Pilot for Tailored APS Intervention. Our presenters are Courtney Everson, Senior Project Director at the Colorado Evaluation and Action Lab at the University of Denver, and Stephanie Woodard, State Program Director for Adult Protective Services at Colorado Department of Human Services. Quick reminders before we begin. Participants are in listen-only mode, but please do put any questions that you have in the Q&A box in the Zoom taskbar. We're going to be monitoring those questions, and the presenters will be able to address those during the presentation today. The PowerPoint slides will be posted in the chat for you to open and download. And a reminder that a survey will pop up at the end of the presentation today with a few questions on today's presentation, as well as your interest in future research to practice webinar topics. With that, I will hand it over to today's presenters.
Fantastic. Thank you so much, Jennifer, for the warm welcome. And thank you, everyone, for taking an hour out of your day to learn more about this topic. As Jennifer said, my name is Dr. Courtney Everson. I'm with the Colorado Evaluation and Action Lab at the University of Denver. I'm joined today by my colleague Stephanie Woodard with the Colorado Department of Human Services. We'll give a little bit more background on each of us in just a moment. Suffice it to say, as we kick it off today, I am so excited to be sharing with you highlights generated from a multi-year evidence-building project on an intervention we call alternative response, and what has really launched a dual-track model for APS response and intervention here in the state of Colorado. Our goal in the next hour is to really present some of the leading research and evidence behind what we learned from a 2-year outcomes evaluation and begin to inspire what this might mean for implications in terms of strengthening and elevating services and supports for at-risk adult and older adult populations. We have a lot to cover and only an hour together, so I'm going to dive us right on in. As we get started, Stephanie and I would love to just get a sense of who is in the room today. We would love to hear name, organization, or perspective, including what state you might be coming from. If you want to just drop that in the chat, that is just something lovely for us to be able to understand as we come into community together. As your presenters today, we'll also briefly give a bit of introduction and background about each of us and the role and perspective we are bringing. As I said, my name is Courtney, and I am with the Colorado Evaluation and Action Lab, Colorado Lab for short. The Colorado Lab is the state's premier research and policy lab, working with all 3 branches of government to help unlock data-informed solutions to drive effective state investments, policy, and practice change. Since the inception of the alternative response practice, we have had the true honor of partnering with the Colorado Department of Human Services to build evidence on this pilot and really find out what might work, for whom, and under what conditions and why. So as the principal investigator for this particular evidence building project, and on behalf of my team at the Colorado Lab, we are thrilled to be here today. Stephanie, I'm going to turn it over to you to introduce a little bit more about yourself, CDHS, and just let me know when you're ready to go to the next slide.
Sure. Thanks, Courtney. I am Stephanie Woodard. I'm the program director here at the Colorado Department of Human Services for the statewide APS program. A couple of things about how we're situated. Our program sits within the larger Department of Human Services at the state level. Then within that, we sit in a division of Aging and Adult Protective Services, which houses our program, and the State Unit on Aging is our sister program. So a little bit about how we're situated. Other pieces that are relevant, I think, to consider in the background as we talk today, we support 60 county programs. So we're one of the handful of states that operate adult protective services and several other of our human services here in Colorado through this county state system. So the state team is responsible for the oversight, the setting of policy, collaborative with our county programs, and training and things of that nature, whereas our county programs are implementing at the local level these services and casework. So we work together in a very highly collaborative manner. You'll hear a lot about that through today's presentation, but that is a little bit about adult protective services. And we have 64 counties. I mentioned 60 programs. A couple of them are shared, but they cover a wide range of geographic and population characteristics. So that factors into our discussion today as well.
Stephanie, would you like to continue on with a little bit more about anything for CDHS on this slide that we haven't highlighted yet?
Yeah, absolutely. So the other piece that I just wanted to mention, as we're sitting inside the Department of Human Services, the goal of the department is to prioritize bold and innovative human services. And within that and upholding that, we have our division's North Star goal that seeks to ensure that older and at-risk adults have support they need to live with dignity and security. And then you see the drill down of the mission, vision, and values of our APS program. Many of you on the call likely will remember all of the work that states needed to do with the dawn of ARPA funding a few years ago around developing operational plans and mission, vision, and values to guide their work moving forward. And we had a great time working with our counties to really take that work seriously, and we have maintained commitment to these mission, vision, and values in the work we're doing. So I think you'll see through the conversation today some of those things that are themes throughout all of these, including client-centeredness, collaboration, and innovation, are really linchpins of this alternative response approach that we are talking about today.
Thank you so much, Stephanie. And thank you, everyone. We are seeing now that the comments and abilities have been technologically enabled, all of your wonderful introductions in the chat. And I am thrilled to see such a national audience having interest in some of the innovations and evidence coming out of our state. So today, as we move forward, our goal is really to review those evidence-based learnings from the alternative response, or AR pilot, and translate those to policy and practice action for your locales. Our flow will be to kind of summarize first and foremost, what are we even talking about when we say alternative response? How has it been structured in Colorado? We'll then spend the bulk of our time really thinking about the evidence building approach we took to build evidence on this innovation and find out if it's something we might want to scale and disseminate statewide and perhaps even nationally. And then, of course, what are the findings behind that evidence building work? And highlighting opportunities to advance best practices in APS using evidence insights. So I'm going to kick it back over to Stephanie to really begin us at the top of that flow to better understand what is the alternative response practice in the dual track model that has been introduced in Colorado.
Yeah, so at its core, the pilot, this alternative response approach is really simple. It is a model that allows us to practice in a more client-centered way based on specific information that APS receives. And it's informed by many years of differential response models, sometimes called alternative response as well, in child welfare across the nation, including Colorado. And our county partners really began many years ago at a grassroots level working on exploring this in earnest. They really just, like with any good innovation, they really began by asking, what if we did this? What if and why not? And so their commitment to the concept at the local level for many years led to a bill, which is linked here on this slide, that authorized our program to engage in a pilot and try it out. And so the pilot is 15 counties. We officially launched after a period of development in 2023 with a 2-year evaluation Our statute also required a third-party evaluation, which is where Courtney and her team come in, and that has been wonderful. So they brought their expertise, and we were able to really speak to what we are learning. So we continue to do it now, despite that evaluation period being over. The pilot is still in play, and so we're just talking about what we've learned. So what is it? Dual practice model allows a tailored APS response based on level of risk. Traditionally, as you all, I'm sure practitioners are familiar, we have practices that are standard. So unannounced visits, when you got to go out unannounced to someone's home to start your investigation, your casework. And then in Colorado, we have what some states may refer to as a registry. We have background checks of the APS data system for certain types of employers that provide services to at-risk adults. And so our findings in the traditional response are reportable there as a potential pre-employment prevention measure. The creation of the model then with two approaches or two options for a response recognizes that through traditional response with that unannounced visit carries some obstacles to engagement. Showing up on someone's doorstep unannounced is not something they like. We know this, you all know that. It doesn't allow for people to ensure that their preferred support networks are there, things like that. Similarly, our background checks require our caseworkers to engage in some conversations upfront about due process that can be an obstacle to engagement as well. So in alternative response, we adjust our response in two key ways to low-risk allegations, and that is to schedule the initial visit, which reduces those negative impacts of the unannounced visit and potentially sow seeds for greater rapport and collaboration. And then we also have outcomes that are not our traditional findings and therefore not reportable in the same way through our registry. The model acknowledges a wide variety of things that APS responds to. A couple of those sentinel cases I just want to speak to give you some idea of what we're talking about. This is things like aging spouses who are both declining, one more rapidly than the other, one trying to take care of the other, who are not likely to be trying to apply to be direct care workers in the system, and therefore this reportability piece isn't of benefit to them. But just really need some support, really need to be able to have some additional support, people burning out in a familiar care setting. And of course, self-neglect is a key type of case that does not have that same benefit to a reportable finding. There is no perpetrator in a self-neglect case. And so wanting to be able to address that a little differently is really crucial to us. So the idea basically asks, what if we could change how we engage? What if we really thought about the functional benefit of our findings and what is it bringing to the table, and whether people might benefit more from a different approach that minimizes some of those obstacles that we experience in the field, therefore reserving that traditional response for the places where it is necessary and more appropriate. So we did develop parameters on how to define low risk. We'll talk about that on the next slide. And with any innovation, as always, there's that philosophical hope, and then there's the need to think about unintended consequences, think about what if there's something we're missing. And so there were a few elements you see on the bottom of this slide that we made sure were part of this, acknowledging that we get reports that look one way, and then through the course of the investigation, they look a little different. There is the opportunity in our pilot to go, oh man, I thought this was low risk and it really needs to be different. So we're going to switch tracks, or vice versa, to make sure that by the end of the case, people are receiving the thing that meets the needs best. We don't know what we don't know. So we wanted to learn from this. We also have allegation level tracking. So that just means that within a case, if you have multiple allegations on a case and one needs that traditional response approach, and one is something else that also could benefit from that alternative response of, finding reportable things like that, then there is the ability to have both within the same case. And one thing not on the slide, but I just want to point out is what we did early and often is acknowledging as a collective system what this is not. AR is not diet APS. It is not a shortcut. And so the intention was to see what would happen if we really were able to, at least in some ways, some really crucial ways, switch up how we engage from the beginning of the case, and hopefully sow some seeds for receptivity to the engagement that we endeavor to have in any case. And the next slide is a visual that sort of just unpacks the model. So not going to read it all to you, but one thing that I'm sure that some of you are going, well, how do you define low risk? So a few words on that. That green column you see in the center there has some the summary of how we did that. So it was a big endeavor to figure out, what does this look like? How do you know what something is when it comes in? How do you know that it can go through this alternative response option? And so we worked together with our counties to determine the things that we have sort of three buckets. There were things that we felt should never go down the AR track. There were things that we felt will always in the pilot counties go down the AR track. So self-neglect will always go the AR track. That seemed appropriate across the board. When there are exclusions, those are the things that we decided should never. Sexual abuse allegations is an example of that. And then there were everything else. So if it doesn't fall into one of those categories, we worked with our counties and set some policy that gave some consideration, some factors to be looking at, and really allows that discretion at the local level to consider a range of factors and make that decision that is most appropriate given their knowledge of the community, the individual, the history, and the like. So that is at a high level what the model is and some of the philosophy now.
Thank you so much, Stephanie. I think it's so important to have kind of just a basic nuts and bolts understanding of how this might look a little different in APS in order to understand our evidence. I want to make just quick housekeeping note as we move forward, which is if you have questions or comments or insights you want to share, please feel free to use that Q&A feature for questions. Our colleague, Dr. Erica Felder, is currently monitoring that on our behalf alongside Jennifer, and will interrupt us at any point if something is a time-sensitive question. Otherwise, we have reserved a nice bit of time at the end to really move through participant inquiries. So please keep those coming in, and we will triage appropriately. So with the foundations of the innovation in mind, I now want to turn us a little bit into the evidence building approach we take. So at the Colorado Lab, we are not your traditional research team. We are not people who enjoy saying, give us your data, let us go into our black hole, and we'll let you know in 2 years if what you did on the ground worked. We are much more about leaning into a genuine partnership and thinking through how we build evidence for innovations and what it can look like to use what we call Colorado's Steps to Building Evidence, which you see here on your screen. This is an approach that really recognizes while everybody commonly wants to jump to some kind of rigorous evaluation like a randomized control trial or a quasi-experimental design, it is so very important that we actually start with model foundations in order to continuously monitor for fidelity. What are the areas for improvement? What's working well? And then to begin to get a sense of what is driving results before we ever get into the outcomes evaluation. And this really allows us to ensure that data is not used just at the end of a pilot, but rather throughout an entire pilot to continuously be responsive to decision maker needs and bring in that partnership from start to finish. I am proud to say that through our partnership with the Colorado Department of Human Services, we were able to move the alternative response pilot all the way up through step 4 building evidence with a very rigorous outcomes evaluation that you'll learn more about here today. Now, as you saw in those steps to building evidence, the very first step is to ask, what are we even trying to move the needle on? And why do we think it'll work? This is commonly, for those of you in the room who enjoyed their program evaluation classes, is called a theory of change. And what we have as our North Star goal here is to enhance that collaborative relationship between at-risk adults and APS to improve safety, promote long-term well-being, and reduce risk of future harm. There's a lot of little outcomes that can go into that to lead to that big North Star goal. Mitigating safety and risk concerns, increasing client engagement, decreasing APS repeat involvement. And how we're going about that is through the practice innovation that Stephanie so eloquently talked about that can really help us to increasingly be person-centered in form and in function. The other thing that makes the Colorado Lab unique is in addition to believing in true partnerships and evidence building, we also believe that behind every data point is a person. And so we constantly take a mixed methods approach to ensure we humanize data. So we don't treat this just as case counts in a fiscal impact analysis, but rather as real lives that we're designing real human-centered solutions for. So I want us to start out with a quote from one of our pilot county caseworkers who says, I would say that with alternative response, the family is more willing to engage with a care plan. Whereas in the past, if we had to say, you're going to receive this letter, you're going to go on the registry, they were like, get out of my house. There was no engagement after that. I think alternative response has supported that engagement, the willingness of clients and families to engage in care. So we started to take this and say, all right, how do we start to deconstruct why that might be true? And our evidence building approach really spanned a number of evaluation activities, including a descriptive study that looked at implementation and reach indicators, an outcome study that looked at causal evidence on effectiveness, a fidelity measurement period throughout the entire pilot to really understand where there were opportunities for strength and where there were opportunities for course correction. And our times period spanned 2 years of implementation, which included all cases that were screened in, investigated, and closed between January of 2023 and December of 2024 across our 15 pilot counties, with a 6-month follow-up period added in order to measure repeat involvement outcomes that you'll learn more about today. As Stephanie mentioned, very importantly, we anchored the outcomes analysis to the case level to reflect how clients are served, but we also wanted to be able to account from an evidence perspective for the fact that tracking can happen at the allegation level, which means you could have a case where you have one AR tracked allegation and one traditional response tracked allegation. Or you could have a case with multiple alternative response allegations, no traditional response allegations. Or you could have a case with all traditional response allegations, no alternative response allegations. So we got the great pleasure and brain teaser of figuring out how to methodologically account for all scenarios. And that's a little bit what you're going to see here in our results today. I'm going to start with something that is more basic than outcomes, and that is the descriptive highlights. And the purpose of this is it helps us to understand who is actually being reached by this innovation. And as I go through these slides, I really want you to be thinking through what this means for some of the participants and clients and populations that you work with, and where an intervention like this might have traction in your locale. So in total, and this really speaks, I think, to the volume of what APS in Colorado is doing. In the 2-year period, there were nearly 9,800 cases, representing nearly 15,000 allegations and representing just over 8,400 unique clients. That is a big volume in a 2-year period. And I think that really helps to speak to the importance of the work you do in adult protective services. And when we looked at this population in descriptive study, we saw that close to half of all APS cases in the sample had only alternative response tracked allegations, which really shows demand for a dual track model. Let me put this another way. If I would have looked at the data and I would have been like, you have less than 10% of all your cases even being tracked exclusively to alternative response, I'm not sure we would have said there's demand for this. It's kind of like this is a pretty minority part of the population. I'm not sure it makes sense to invest in this on a systems-wide level. But that is not what we're seeing. The AR track is being robustly utilized by the pilot counties, and it really signals that need to tailor response to level of risk. We also ran in the descriptive study classic statistical tests for significance, and rural counties, as you can see on the screen, inherently have more cases utilizing the alternative response practice. I want you to keep that little tidbit in the back of your mind because you're going to see some patterns happening with our rural counties that really reflect a changing demographic and an aging demographic. Second insight I'll share. Self-neglect makes up over half of all AR tracked allegations, really showing, again, a significant use case for the alternative response practice. So you see this breakdown. Once again, you see it significantly higher in our rural counties. And this makes intuitive sense because remember what Stephanie said is that all allegations of self-neglect inherently go down the alternative response track. Okay? But there's also a set of mistreatment allegations that could also go down this track because they are considered and deemed lower risk. And you're beginning to see that breakdown here on your screen of how it sort of shakes out on the whole between self-neglect and mistreatment. I will now give this little tidbit from an implications perspective. We inadvertently learned a lot about caring for a population experiencing self-neglect through this pilot because it was such a robust portion of who was reached with the innovation. Third insight from the descriptive study I want to share. The alternative response practice is reaching a high number of clients who live alone and have fewer support networks. Okay, this is super duper important. This is one of the most interesting findings, in my opinion, from a descriptive perspective. Because when we really began to break this down in a robust way, we are really starting to get clues into the impacts of social isolation on at-risk adults and an aging population. And we know that clients with only AR tract allegations are significantly more likely to live alone compared to the clients who are being tracked to traditional response. Okay? And we know that living alone is a proxy for social isolation. We also know from this study in the broader literature that social isolation is heightened by that lack of support networks. And again, support networks were lower for clients with AR only cases, so cases with only alternative response tract allegations compared to our traditional response cases. This is really important because when we think about precision staffing, I often talk about this in our human and health service systems. What are you doing to train clients on, or not clients, excuse me, staff on what types of clients they might be experiencing and walking into a room? Are we ready with resources for building up social networks? Are we ready with resources to combat social isolation? When we're dealing with a high level of self-neglect population and an aging population, this is going to be key in a lot of cases. And that's something that we very quickly discovered in the descriptive study. That last insight also articulates with this one, which is the alternative response practice reached a high number of clients with conditions that reflect an aging population. You can see that broken down again for all pilot counties and our rural and urban counties within the pilots, really seeing dementia and Alzheimer's as one of the leading conditions. And I think this is so very important to be thinking about the difference between our rural and our urban communities in the types of conditions that might be dominating cases coming into adult protective services. Now, with that kind of teaser into who the pilot reached and some of the clientele that we have an opportunity to really better serve and to continue to improve response levels to level of risk, or response approaches, excuse me, to level of risk, I want to turn us to our outcome study. Stephanie and I have had the privilege, alongside several of our colleagues, of presenting at the NAPSA conference for several years now. And this last conference in the fall was held in Seattle, or Bellevue more specifically, Washington. And it really struck me that in the opening remarks by Bill and Bob, often commonly referred to for those of you who've been to the conference as the Bill and Bob Show, that they said one of the things that adult protective services often doesn't have nationwide is really good outcomes evidence on does this work and how does it work and why is it so important. And those outcomes data are critical to being able to advocate for adequate budgeting and resourcing, to be able to inform policies and practice solutions that really help support the work on the ground. And I am so very thrilled to be turning us to results of a rigorous outcome study that can hopefully help lead out nationally on what's possible in outcome studies for APS and how you can use these results in your locale. So first, for 5 seconds, if research and data is what flips your pancakes, you are going to be in for a thrill for about 2 slides. If this is not the thing that flips your pancakes, you can tune me out and go get a glass of water. This is about the methods. So we did not go with a randomized control trial for this study. or what's commonly talked about as an RCT, we went with the next best available option, and that is a quasi-experimental design. As a state, we chose to say this does not feel ethical to be randomizing adults to one or two interventions at this level, given it's a response intervention. So we chose a quasi-experimental design instead that still allowed us to match and control for all of the factors that could confound a study and make sure we can make any results be directly attributable to the intervention at hand. We were able to really generate causal evidence using propensity scores and the ability to find what we're going to call equivalent or control cases to the intervention cases. Our total analytic sample was 14,641, and we break it down into AR cases, think about that as your intervention cases, and AR equivalent cases, think about that as your control or comparison group. And our AR cases are any cases in the pilot period that contained one or more allegations tracked to alternative response. And our equivalent cases were cases that would have had at least one AR tracked allegation in the past had a dual track model have existed, right? We're identifying their equivalents before this intervention was online when the policy lever was triggered. A way to think about this in terms of our intervention and comparison cases is what is the comparison periods? Instead of comparing our pilot counties to our non-pilot counties, we chose to make the comparison period be the policy lever that enabled that dual track model. So a 2-year before period and a 2-year after period. And the reason this is very important is because Colorado is state supervised, county administered, and APS. So comparing our 15 pilot counties to non-pilot counties would introduce so many confounding factors that we would not be confident in the results of the intervention and whether or not they were truly attributable to the alternative response practice. So we chose a different way of establishing those comparison groups and comparison periods. And now you're back from your glass of water, or you're like, tell me more, in which case, don't worry, there's a full evaluation report forthcoming that will give you all those details. But most of you want to know, so great, I believe you, rigorous evaluation, what's the results? Outcome 1. One of the leading outcomes I'm going to spotlight here today is that the alternative response practice reduces repeat involvement in APS. You can see these results here on your screen. AR cases are 2.5% less likely to have a second screened in case within 6 months of a case closure. This is very important, and we're going to reserve some time here in just a little bit for Stephanie to talk more about what it means for having implications of each of these results. But I'll just tee it up here that anytime you have clients who do not come back into APS and into our system utilization, you have cost savings and cost offsets, including in caseworker time and the ability to really precision staff adult protective services. Now, you can kind of see these results. This is for all of it. No matter if it's a self-neglect allegation or a mistreatment allegation, AR cases are 2.5% less likely to have that second screened in case within 6 months of closure of the first case. But you might be wondering, cool, how does that break down? So this is where I think it gets particularly interesting and compelling. When we looked at the reductions or potential reductions in repeat self-neglect, we saw that AR cases are 7.2% less likely to have a second screened in case for self-neglect within 6 months. So you take your cases with self-neglect, they go through, they close out. Did those same folks come back 6 months later with a self-neglect allegation? The answer is, with the intervention, they're 7.2% less likely, dropping that from a 17.2% value in our comparison or equivalent cases to 10% repeat involvement rate in our AR cases. That's a big deal because that means something's happening to stabilize those clients in situ, that they are getting safety and support services put in place that can get them connected to other community-based services. You know, agencies that help an aging adult population, not necessarily needing to come back into protective services when not necessary. But wait, there's more. I'm like an infomercial for research. What about mistreatment? This pattern held true for mistreatment as well. AR cases are 11.8% less likely to have a second screening case for mistreatment within 6 months of the initial case closure. So something's happening here to say this innovation, this alternative response practice, is not only reaching our self-neglect population, but also our low-risk cases of mistreatment. Now, let's go a little further. That is a big outcome for clients who might not want to be re-involved in protective services and want additional ways to stabilize themselves in community and with their networks. It matters for the system, but let's go a little bit deeper into what else matters. And this is something that can really matter from a day-to-day work perspective. So the alternative response practice reduces case length. For AR cases, total case length is reduced by 5.63 days compared to their equivalent cases. Now, what's fascinating here is when you look at this breakdown on your screen, the reduction isn't coming from somehow this being like, the shortcut version, as Stephanie put it earlier, but rather it's coming from quicker completion of client baseline assessments, fewer days in determining findings, if it's traditional response or conclusions in the AR pilot, and a shorter window between the date of last finding and that conclusion and case closure. Now, this is important because when we digged into the qualitative methods behind it and we asked caseworkers and staff, why might this be happening? Are you taking shortcuts? What's happening? The answer wasn't that. The answer was that by creating some key function differences, such as being able to schedule that first visit, not just showing up unannounced, being able to not have the looming threat of a substantiation and a finding, they were really able to create increased rapport building faster. And when that trust happened faster, so too did the ability to have an honest and frank conversation that could help uncover strengths and create that improved ability to actually tailor a case plan to what those clients needed. And in turn, that can shorten case length. There is also a reduced documentation burden simply because there's not needing to be a preponderance of evidence the way there would be in traditional response. So that is also helping from a case efficiency perspective. When we think about an ever increasing budget in the world that is tightening and shortening and shrinking, unfortunately, in most states, we really want to be thinking about how do we do good, meaningful work with tighter purse strings. And where can we find those system and case efficiencies without compromising client service delivery? This innovation is showing us this might be one way, tailoring to the level of risk. Third outcome, the alternative response practice is being appropriately applied. Okay, this is big, y'all. So one of the things that when we saw this particular policy pass with Senate Bill 21-118, that legislators in particular were asking us was, what happens if it increases harm? What happens if you miss something? What happens if it's being inappropriately used? So we really wanted to track this. And what we are seeing here, and I can simplify this graphic for you, is that we would really want to be able to see that low risk is actually being applied when it comes to mistreatment allegations. How might we know it's low risk? Well, one way to determine that is to think about the percentage that actually have a severe or substantial rating at the end of the case saying, yeah, this allegation happened and yeah, there was severe or substantial harm potentially done here. That should be pretty minimal. And you see that in the red. The majority of it should actually be, very little to no impact. And what we were seeing is that the ability to move those low risk cases out of traditional response and into alternative response really help match response level to what is the likelihood of harm. And so this gives us a lot of confidence that this dual track model helps meet that goal. And there are solid decision-making skills by APS staff on the ground that are making these track decisions. Now, in the words of one of our participants that I really think helps highlight how could a mistreatment allegation be low risk. They said, quote, our AR tracked allegations for caretaker neglect. A lot of times, that is a husband who is struggling and likely they just need help. They just need Medicaid or they just need respite. So we can really see how having a dual track model helps us to meet the root causes, not the symptoms. Final couple outcomes I want to highlight here before I really open it up to have a conversation with Stephanie around implications. We're getting into some of my favorite outcomes, you all. I am a big fan of how do we reduce social isolation as a risk factor for mistreatment and self-neglect, and how do we improve support networks for being a protective factor. And what we see here is when the APS county staff actually engaged the client support network, whether that is like their daughter or their neighbor or a close friend, the likelihood of client refusal of APS help went down by 1.10% for each additional support. So this was a dose-dependent effect, okay? So the minute you say, yeah, actually, can I schedule that visit? Yeah, Tuesday works for me. Does Tuesday work for you? Great. Also, you are allowed to have somebody there. Would you like somebody there? And they're like, oh, actually, I would. I would like my daughter there. I'm not totally sure I trust you, especially with our aging population, right? AARP said, don't just randomly show up at my door. And I just don't know about you. Engage with that daughter. That daughter maybe brings somebody else that that client trusts. That means there's two support networks. The likelihood that client is now going to refuse contact is going to go down by 2.2%. So it's a dose-dependent effect. In a fascinating turn of events, this turned out to be just good practice. It didn't matter what track. Anytime you engage a support network, there was more client engagement. There was also a trade-off, and that is for support networks engaged, case length increases by 7.37 days. We would argue from an evidence-based perspective that this is a worthwhile trade-off. I think it is much better to have collaboration takes time. We all know that. And that collaboration can lead to those outcomes we just reviewed and increase that client engagement as a driver of those outcomes and is likely worth the extra days on a case. And then this outcome is another one of my favorites because it really helps us to start to tailor our responses and our innovations to our geographic differences and our community differences. So I think about this one a little bit with an analogy of fall prevention, where there's a statistic that circulates nationally that like less than half of older adults who fall ever talk to their doctors about it. They go in for their doctor visit and they're like, any other concerns? They're like, no, absolutely not. Don't worry about the bruise on my hip. So we have to be more proactive in how we plan. And interestingly, when we looked at refusal of contact, in urban counties, it was about 3.85% on average, and in rural counties, it was 7.21%. And the higher refusal rates in our rural counties often will reflect higher rates of frail elderly clients. Remember that earlier outcome of REACH, who commonly might have a higher cultural mindset of autonomy and aging and the need to improve what that looks like to outreach in a more universal kind of way. So one of the key recommendations that we've uplifted in this evidence building work has been how we get something like motivational interviewing that many of you might be trained in into more APS staff trainings and professional development opportunities to really begin to build that client rapport and engagement from case start. As a reminder, we're going to turn into questions and answers here and some discussion in a moment. If you have a question and answer, please, or a question and answer, we should answer it. If you have a question, please drop it into the chat for our monitoring. So I'm going to end here and turn us into our discussion. I want to end with another quote, again, bringing back the humanistic element to the data and the rigorous numbers that we've just departed. Today we had just a spotlight on a few of the leading results. There's many more that are in the evaluation report and some more in our policy brief we are sharing today as well. But this caseworker reminds us, quote, I really appreciate being able to build some of those relationships with our clients prior to us going out and seeing them. I think it helps with some of that pushback and just being like, oh my gosh, someone's here at my door. What do you want? Versus, hey, I would like to come and help you. Is it okay? I think that the AR practice helped build some of those relationships, especially with our self-neglect case clients. As we turn it to our discussion, I do want to just acknowledge the fact that no good innovation, no good policy work, and no good practice work ever happens in isolation. Huge thanks to this group for having us. Huge thanks to Dr. Felder for really helping behind the scenes to make this happen. To the individuals at CDHS, Bettina and Elena, who really helped to create and spearhead their leadership around this work. To my team, Dr. Rafi Ramirez and Aaron Wickerham. And of course, to our 15 pilot counties, who I'm sure are tired of me saying the word fidelity and sharing outcomes, but also have really leaned in to data for learning and moved a vision into action in a way that has led us to the ability to have a potential for statewide scaling of this innovation. And that's where I really want to now open it up to starting to answer some of the questions and answers in the chat, and really to start to get Stephanie's thoughts on what we've begun to think about with these key topics I've reviewed that are now on the screen for Colorado and start to inspire, right, some action for our other jurisdictions. For the purposes of time, I'm going to actually see if there's any initial Q&As that Erica or Jennifer, you would like to elevate for us before we kind of connect it to some of what's on the screen here.
Great. Thanks, Courtney.
Sure.
Thanks,
So
Stephanie.
go ahead, Jennifer. Sorry.
I'll start off, Erica, and then you can follow up. One question, could concerns with someone's cognition ever change a self-neglect allegation from AR to TR?
Great question. No, we were just to get back to that point of the why behind this. We were really centering the idea of self-neglect going down the AR track in all situations, not around the difficulties that the individual has or individual needs, because we really just believe there is no functional benefit to a traditional finding in a self-neglect case because there's no perpetrator. So it's really important to keep that philosophical distinction. Now, the individual needs of the person obviously impact how the case planning goes, and it's important to note that in the AR model, there is no difference in the expectation of how we assess to risk and safety. I think there's a question coming up, so hopefully I'll target that right here. Was the same assessment tool used for both tracks? Yes, we have a risk and safety assessment tool that we use to identify in a variety of domains what the needs of the individual are while we're investigating the allegation. And that tool did not change with the two tracks. It's used in both. The expectations around identifying unmitigated needs and case planning to those did not change. So it does not impact the ability to seek supports that are specific to that person. We just hoped and have seen, I think, the benefit that it does impact the receptiveness potentially of them taking us up on those supports.
Great. Thanks, Stephanie. Another question, what technology hurdles were there in implementing this pilot? Did you make any changes to your abuse reporting system to accommodate the pilot procedures and processes?
Yeah, so we have statewide case management system that takes all county records, and we did have to make some changes, not to the intake itself. Reports come in the same way, but it is the screening process where the track assignment is made, where counties are determining whether this meets low risk criteria or not. And so within the system, there were a number of changes we needed to make to accommodate, to be able to pull data, reflect which track a certain allegation is assigned to facilitate that digital version of the track change if that happens, to help screening decisions reflect which of the criteria was leading to tracking one way or the other, things of that nature. And of course, we needed to create the sort of corresponding fields because there's not traditional findings. There are outcomes that and conclusions where we say this as alleged didn't occur as alleged, or what was the safety impact to the individual. We created that sort of mirrored data entry piece for that track.
Great. Next question that was posted here is how long do workers have to make initial contact with the client in both AR and traditional track cases?
Yeah, so our requirement is depending on emergent or non-emergent. There's an emergent response, which is never alternative response, that is 24 hours, and then we have a 3-day business day response for non-emergent situations. That was one of the things that we needed to sort of adapt to throughout. So there was some challenge in folks trying to get, okay, we're called, but I'm not getting a call back within that third business day. Oh, when do I shift? And so we really needed to work collaboratively with our county's duty process to determine, okay, what does an attempt to schedule look like, and where do we have latitude within the existing rule structure? So typically, it's possible that it goes longer to get that scheduled because we reflect in our policy around this practice that the counties can take that attempt to schedule as their initial, and then they can wait for the call instead of feeling like they had to rush to, schedule if they didn't get a call back. But it is an implication that hopefully if we can scale, we will be able to fine tune a little more. But we have that 3-day is the at least try to get it scheduled.
And may I just add a little bit to this because I love this question. And I'm just going to flip us over to a slide that I just unhid on my end because I think it's an important element of understanding some of the hurdles to Stephanie's point. So there was some changes, right, in terms of what it looked like to have time to schedule that initial vision, that initial response. And you heard us say from the very beginning that one of the hallmarks of this practice is the ability to respond both timely for the purposes of safety concerns, as well as have that flexibility to schedule in order to build that collaborative engagement. In the graph that I've just put on your screen was one of the fidelity metrics that we measured from the very start. And we set a pretty high bar of 70% of initial responses, should be scheduled and scheduled within that time frame that Stephanie's just talked about. If the allegation is going down the alternative response track. And this was a big moment for not just structure and practice change, but culture change among caseworkers. And I think you see that in the increasing progress that our counties made toward fidelity for this particular benchmark or criteria, but they never actually, on the whole, the pilot never actually met that high threshold we set out. And so that continues to be an area that all of the strong results achieved from the rigorous evaluation, I anticipate are going to get even stronger as we continue to drive fidelity in this one and really think about how long folks have to respond and how they thread the needle between timely response for safety and being able to engage in scheduling that initial response for collaborative engagement. So just wanted to kind of add that in because I think that question really tees up some of the data-informed learnings to how to make this feasible and where you might expect some pain points to pay close attention to.
Great. Thanks for sharing that, Courtney. Stephanie, I think this question might be for you. Do staff carry a dual caseload or were they assigned to only one or the other? And what happened once a case track changed?
Yeah, so because you can we track at the level of the allegation, and when reports come in, sometimes there are multiple allegations on a case. There's no split. It's not like a person I only do AR or I only do traditional response unless the county was just doing that for the cases that were solely tracked one way or the other. So I guess you could think of it as a dual caseload, but it's truly like there is not a difference of needing to explore, did this happen? There's no difference in needing to investigate the allegation, but what we're doing is we're looking at how we approach it from the jump. We're looking about how we talk about it with folks during the process and what the impact of the outcome is, whether we're talking about a traditional substantiation with reportability. So there was some concern, I think, early on when we were planning, is it going to be hard to keep track? And what we saw and heard from our caseworkers is it wasn't as challenging as they thought. It's really a matter of deciding in that moment, if you have two, how are you going to approach the individual situations? The perpetrators are typically two different people in that situation. And so we've learned quite a bit from anecdotal conversation, case consult, things like that. But and as far as when the case track changed, obviously you can't go back in time and change how you scheduled or didn't schedule the initial visit, but it does allow us to right size how we're speaking about and what we're doing with that finding on the back end. And so that is really important, whether we need to sort of put it in that category of traditional and reportable on the registry or not.
Great. There's a few more questions here that have come in. Do you attribute the decrease in repeat self-neglect and maltreatment cases within 6 months mostly to increased engagement with the clients, or are there other reasons you've identified?
Yeah,
Happy to
I mean, I
begin and have Stephanie, you start us off too. Go ahead.
Yeah, I think Courtney spoke to it pretty well. I think that is our primary driver, because truly in this model, there really isn't much else different. We've made no changes, again, to our standard practice for assessing needs for what we're asking people when a report is put in and what the case planning process looks like. This truly just changes how they initiate the interaction and the ongoing case involvement, and how they're talking about what they do with the information around the finding or conclusion to the case. So what we're seeing is that barrier that we all know, and it is something that we wrestle with. We've never approached APS as a way of doing casework that isn't supposed to be person-centered. We've all talked about being person-centered for years in this field. AR didn't allow us to be person-centered where we weren't. It allowed us to sow seeds where that effort was less of a hurdle, because some of the process could be different where merited, and we could actually sort of not be fighting as much of an uphill battle, so to speak. So we believe that it is about that receptivity, about laying the groundwork early, that we're here to help and what can we do, and this doesn't have to be as intimidating as it may be if this were traditional approach.
Mm-hmm. Thanks, Stephanie. I'm just going to add a couple of pieces because I can also see the next question that I will read out loud, and I think it connects, which is, did the AR track improve clients being receptive to linkage with other community partners for other services? So this is where, once again, I have the beautiful technology to be able to unhide slides. And it's like you all are all predicting what was in my hidden slides, because here's a little bit of an interlude that reminds us that not everything behaviorally and relationship-based wise can actually be measured in administrative data like we did all these other outcomes. So in the administrative data, we actually did attempt to measure client engagement and service provision to answer exactly what the question is around, did we see kind of correlation with linkage with community partners, service provision, service uptake, case planning, et cetera. Those results went in the right direction, but weren't statistically significant. But I think it reminds us that not everything that counts can be counted, and not everything that can be counted counts. And I say this because when we looked at the qualitative methods behind this, it's everything Stephanie said, and one additional piece I want to outline, which is that many times, especially in smaller knit communities, APS caseworkers are neighbors. They see clients at the grocery stores, right? We live in communities, not in systems. And so the ability to have small but profound tweaks to APS response that increase that receptivity to the APS staff, then in turn created less of a barrier to be able to say, and receptivity to community partners and the services that you are recommending in my case plan. And when those connections can happen, what we learned from the qualitative side of this that I did not highlight as much today, but one of the biggest themes was that ability to then stabilize clients' well-being and reduce future risk of harm by connecting people with those community services and supports in an increased way than would have been done if APS staff had not been involved. So that's the piece I also want to just kind of add, that this is the benefit of a mixed methods approach that allows us to get out the why and the drivers behind some of the results with repeat involvement as an example.
Great, thanks. We have 1 minute left. There's a couple more questions. Do you want to take those now, Courtney and Stephanie?
I think in respect for time, I think we'd love to put out maybe some, Q&A that as a follow-up.
Mm-hmm.
And if it's all right with you, Courtney, I'd love to just sort of close maybe on that self-neglect piece.
Please.
We talk a lot about all the pieces of this. This wasn't dedicated to self-neglect, but one of the prompts here on the screen that Courtney had proposed is, hey, what does this mean? How this is a growing topic nationally. What does AR tell us about informing that conversation. And I just feel like this goes for this and any other piece. If our work can inform anything you are contemplating in other states or the field as a whole, I would hope that it just validates the importance of driving policy that is centered around impact, that asks why not, what if, and that is really elastic in nature. That is a dance that we all have to try to navigate. It's really hard to know how to give structure that allows discretion and be able to adapt. And everybody has different requirements about when you got to change a law or whatever. But I just highly encourage states, if you are pursuing any innovation, this or anything else, that we really be asking ourselves all the time, is this actually doing something beneficial or taking us further toward the mission? Or what is that benefit? What is the functional benefit? And when it's chafing and it doesn't feel like it's meeting it, it's okay to try to rethink it and take the time to do that, because we have seen some very good results from that. So
Thank you, Stephanie. That was a perfect closing. I appreciate your time and Courtney, your time as well. There's a lot of comments in the chat of how much they've appreciated. The participants have appreciated this presentation. As a reminder, there'll be a survey that pops up when you close out the webinar, and this recorded webinar, along with the corresponding research brief, will be posted to the NAPSA Research to Practice website. Thank you again for your time. Thank you for all who joined today's webinar, and have a good rest of your day.
Thank you.